Good afternoon. My name is Ann Brazo. I'm the CEO and founder of MPN Advocacy and Education International. Many of you know me from years ago. I was at the MPN Research Foundation. We still love them dearly, and we'll work with them any chance we get. They're doing great work in research for MPNs. We are here today to talk to you on Veterans Day, and most of you on this webinar are veterans or the spouses or family member of a veteran. In this case, Vietnam veterans, but there may be others as well. Many years ago when I was at the foundation, I worked there for almost 9 years. We got many phone calls from Vietnam veterans specifically who had polycythemia vera and myelofibrosis, and they would share their stories with me, and they were pretty compelling stories that their exposure to Agent Orange was probably a component and a possible reason why they had an MPN. So after I left the foundation and started this organization, I really wanted to spend some time doing more advocacy work in this space. Thus, we began, Kathleen, Michael, and myself started working with Congress folks, and I was spending a lot of time in Washington, D.C. at the Veterans Administration. And it turned out that we really had to have some proof, some science behind our allegations, if you will, that, you know, over 500 people in our database had an MPN, and they all happened to be Vietnam vets, and they all happened to be exposed to Agent Orange or to benzene or other chemicals in these wars. And so we talked to Dr. Raajit Rampal from Memorial Sloan Kettering, who is with us today. And thank you so much for being here. And Dr. Rampal and I have had numerous conversations about where do we go from here, because he actually attended meetings with me in Washington, D.C. at the Veterans Administration. And as it turns out, you know, we just constantly, for years we did this, and we've taken this break during the COVID pandemic. But and I can let Dr. Rampal speak more to this, but it's extremely frustrating for us. So I can only imagine how frustrating it's been for you. This population is not getting any younger. The irony of all this and what we discovered is there are many patients that do get compensation for their MPN from the Veterans Administration. And so we have two arguments here now. We have the scientific argument. Once we can make, you know, do some scientific work that backs up our contention, but there's also this disparity in who's getting compensation and who isn't. And it had nothing, you know, when we looked at some of the nexuses that were sent to the VA, there was really no hard evidence that those people getting compensation had comorbidities. It was just a, you know, person here, person there. There was not any consistency in how they were getting the benefits. The only thing I have personally come up with is who's helping to write the nexus, who's filing the complaint, or the, you know, forgot the word, but, you know, who's, pardon me, claim, sorry, just disappeared. Anyway, so who's filing the claim, who's helping with file the claim. We've put numerous information on our website under advocacy. You can go there, and Kathleen Michael, who's with us today, did a brilliant job of putting information on that page for you. Because what we did discover was, you know, and many of you can kind of attest to this, is some of the VA places where they go to get help. Some of them are very equipped to help and know what to do and know what to say, and others simply don't. It's like school districts, you know, there are school districts that are, you know, very wealthy and that can offer so many things and have so much available to them. And then there are school districts like I grew up in, and many of us grew up in, that have very little, and they don't offer the same things that the other schools offer. And so those are the only things that whirl around in my head, that why is this disparity present? And so our goal in 2022 is to start working with the VA, and Dr. Rampal will definitely be in charge of the science aspect of this. And we are going to go back to DC and talk to the internal affairs people about the disparities and who's getting benefits and who is not. So at this time, I would like to introduce, to those of you that do not know, Dr. Raajit Rampal, Memorial Sloan Kettering. He is a wonderful person. He's a great physician. We send lots of people his way, and always willing to help. And we've been around the block on this, Raajit, but I'll turn it over to him, and we'll go from there with your questions. Thanks. Thank you, Dr. Rampal.
Thanks, Ed. So hi, everybody. This is perfectly timed, of course, to be on Veterans Day. And I think that has to stay at the heart of what we're trying to do here. But I guess taking a step back, why are we interested in this question, right? Of course, there's a scientific part of this, right? If there is something like Agent Orange that can cause MPN, that means that there are other things, other chemicals that can cause MPN or other cancers, right? I think that's sort of one of the high level reasons why we're interested in this question. But of course, then there is I guess what I would call the moral argument, the more important argument, which is that we should study this because it's the right thing to do. Because we know, taking this out of the MPN space, we know that there are clearly cancers that even the VA says are associated with exposure to Agent Orange, meaning that our veterans were harmed by this agent. And that's the truth, because we know that has been, validated in other studies. And so thinking about our patients, our MPN patients, does the same thing hold true? We believe it does, for a variety of reasons I'll get into in a moment. But at the end of the day, beyond the science, this is the morally right thing to do, is to ask this question and resolve this question, hopefully in the right way. What do we know? I think, as Anne pointed out, we don't have direct evidence, and I don't think that's a reflection of there not being a link. I think it's a reflection of how difficult it is to answer this question, right? You all know that MPNs, as they're diagnosed now, really weren't diagnosed this way way back when, and way back when means pre-2005, right? We didn't know any of the genetics until 2005, and more recently until 2013, more of the mutations that cause it. And so, what may have been considered an MPN in 1985 may not be what we would consider it now, or probably more likely, it would not have been diagnosed at all. I think that's probably the bigger reality. And that's part of the problem we're dealing with, is a huge time gulf between the event, and let's call the event exposure to Agent Orange, and where we are today. And then there are a lot of logistical challenges in terms of how do you get samples to try to do science to prove it. It is not a straightforward thing. As Anne keeps telling me, the veteran community would give a vial or 5 of their blood tomorrow if I could tell them, hey, I can solve this problem. I can, and that's an important thing, but there's a lot of logistical red tape that goes into that. And how do you get the study approved? How do you do that? What's the right design? Those are important questions and things. We'll come back to that in a minute. Now, why would we think that there is an association, right? The first thing is that, are there other examples of let's say, environmental toxins leading to MPN? And the answer is yes. So one of the great examples from history is the dropping of the atomic bomb in Hiroshima, where there were studies done of people who survived that. And the people who were really closest to where the explosion occurred had a much higher increase of MPNs. A lot of it was CML, chronic myelogenous leukemia, but also myelofibrosis. There was actually an increase in the rate of myelofibrosis in people who had direct exposure to radiation from the atomic bomb. That is a really important piece of evidence. But even beyond that, there are clusters in the US that have been well described of patients with MPNs, particularly with PV, who have been living, for example, near Superfund sites. There's a well-known example of this in Pennsylvania, where there were a group of people who were diagnosed with PV in a cluster, who all lived near a Superfund site, right? And for a disease that is 1 to 2 in 100,000, that shouldn't happen unless there is something there causing it. It doesn't really make statistical sense. So none of these things are completely direct proof, but one doesn't really need direct proof. I think that's sort of enough circumstantial evidence to say, hey, look, there's a connection here. Now, going beyond MPNs, as I mentioned, the VA has designated a number of other cancers as being likely associated with exposure to Agent Orange. And so these things include, I think, prostate cancer and a number of other cancers. And so it's sort of really hard, in my mind, to have an argument that says X, Y, and Z cancers can be caused by this agent, but MPN, which is a cancer, can't be, right? That is part of our interest in exploring the question, but also one of our frustrations. Maybe more specifically, if we think about blood cancers, there is an established association. I'm going to try to share my screen. Give me one. Are you able to allow me to share my screen at all? If not, it's okay.
Yes, Mallory's working on it right now. Yeah. And while she's doing that, I do want to say there are, I think, 4 blood cancers on the presumptive list right now: hairy cell, B cell, multiple myeloma, and one other blood cancer that is on the presumptive list. And so it is very frustrating that MPNs aren't. But go ahead, Raajit, if you want to share your screen.
Yeah, I'm going to show you something which pertains exactly to this, right? So this was a study of something called MGUS, monoclonal gammopathy of undetermined significance. What MGUS it's a condition that can lead to multiple myeloma. It's not uncommon in the general population. So it happens as people age, and there is about a 1% per year chance that an MGUS will progress into a multiple myeloma. A lot of people have this. A lot of people don't even know that they have it. But the question was asked by a former colleague of mine, Dr. Ola Landgren, who actually was the chief of myeloma at MSK before he's moved on to Miami. He actually did a study, and he used samples that were collected from veterans. They were actually collected in 2002, and this consisted of veterans who had both had exposure to Agent Orange and something that was called Operation Ranch Hand. These were Air Force veterans who were involved in utilizing Agent Orange. So they had some direct contact. And what he did is he used the blood samples that the VA had collected from these veterans and compared it to a cohort of veterans of the same age, gender, essentially really well matched, who didn't have that exposure, who never had any known exposure to Agent Orange, and just asked the question: was the incidence of this MGUS higher in people who got exposed? And the answer was yes. So essentially, he compared 479 ranch hand veterans versus 479 veterans without exposure. And what he found was that there was a 2.4-fold risk of increase in MGUS in the ranch hand veterans. Now, 2.4 is not a huge number, but it's a number and it's significant. And again, because MGUS occurs in the general population, it is, striking, I think, that there is a significant change, that there is actually an increase in people who, in veterans who had exposure to Agent Orange, right? So this is, I think, probably the most recent proof that I'm aware of blood cancers being involved in exposure to Agent Orange. So I think this is an important paper, but actually to us, this may offer a strategy for something we want to do, and I'll talk about that in a moment. Now, what can we do practically speaking, right? I think, as Anne has pointed out, what has not made any sense is why do some veterans get benefits and then others don't, right? Even though they have the same condition. I don't know the answer to that, but I think it is likely in how this is explained when these letters are written, and probably also in who's reading them, right? And there's going to be heterogeneity there. So one of the things we can do, practically speaking, is that I've written several of these letters, and I have a template that I use, which basically points out, goes through a patient's history, says there are no other factors, if there are no other factors that are likely to have caused their MPN. I cite the literature that I've talked about in terms of environmental exposure being relevant. And I think that has been a useful template. I've actually given it to other physicians who take care of MPNs. And I've also shared it with Anne, and I've told her that she has permission to share that with patients to give to their physicians as a templated example of how a letter like this can be formulated with the appropriate evidence cited. So that is something again, Anne has that, and I'm happy to sort of make that available, because that can be useful for your physicians if this is something that you are trying to obtain. Now, the second thing is, what are we all trying to do? Anne has mentioned, what we're all trying to do from the advocacy standpoint, but I think that there is maybe an opportunity to use some of the samples and data that have already been collected. So, the ranch hand study that we just talked about, we got interested in that and wanted to ask the question, could we use those same samples to ask this question in MPN? And so prior to the pandemic, we were actually able to at least start a conversation about that with the person who I believe is at the CDC, who had actually helped Dr. Langren do this study, and she was receptive to the idea. Obviously, because of everything that has happened in the past 18 months, we've been a bit distracted. But I think that is still, to me, one of the best links that we have to try to pursue this. And that's our intention, is to continue the conversation with the people who have collected these samples to see, can we find a way to access that and ask the question that we think is most relevant. So I think from my perspective, top to bottom, that's the scope of the problem and what we're trying to do about it.
So you mentioned a couple things, and the letter, which I thank you very much for that, and we do have it. And what I want to clarify is that if your physician could sign their name to that letter, correct? And that can be part of what you send in for your claim. So just to give you a brief description of what you need to send when you're with the person at the VA office in your area, it's the most concise, the better. And so you have all of your papers from, discharge and when you went in, where you were located, and how long you were there, what exposure did you have? And it could be exposure to Agent Orange, it could be exposure to benzene. We learned that in some cases, Agent Orange was mixed with benzene to liquefy it to better spray. There were 6,741 or 42 sprays over 10 years of Agent Orange. We have so many stories from the veterans that said, they were told to cover their ammunition, but not told to cover themselves. And that the water, ponds and scum and so on was, even though they had things to mix with the water, there were very strong possibilities that, they ingested some of this stuff. And of course, the people that live there, the civilians, many of them are sick. And so, getting back to my point, you have to be very concise. So all the paperwork from the start to finish of your service, where you were, the exposure, and then a one-page nexus should be attached. Your medical records, when you were diagnosed with an MPN, and this letter would be very good to have from your physician, and the language you can use from Dr. Raajit's letter. And then everything, from I was, I either enlisted or I was drafted into the service at this time. This is where I was located. This is the contact I had. This is when I was diagnosed, and this is where I am now, and needing assistance or, seeking benefits. And I believe, Kathleen, if you're there, I think we have a lot of examples or how-tos on our website. Are you there, Kathleen?
I'm here.
Hi, and I do want to acknowledge Kathleen because she did a lot of work putting this page together for Vietnam vets and for veterans, period, but for Vietnam vets in this case. But can you talk a little bit about what you have there?
Yeah, and I'll mention that I'm putting my information in the Q&A and in the chat so people can reach out to me directly. I see one person has said they filed for benefits and they were rejected. That is almost always going to happen because MPNs are not on the presumptive list. So I'm not aware specifically of a case that hasn't been rejected first. Typically on appeal is where we see they get approved. And we have a lot of examples. And as Dr. Rampal said, that what they're looking for is, because it's a slow growing disease, you can't say it didn't, most people aren't diagnosed when they return from service. There's a lot of information now with these veterans who've gotten their benefits approved that make this case as to why we're finding it's happening more, 20, 30 years down the line with diagnosis. So I'm happy to provide anybody with samples of that with the letter that Dr. Rampal created. And it just helps with very simple language that says your doctor believes that it was most likely your MPN was a result of your exposure to Agent Orange. So we find that alone has been very helpful in what we have seen many cases approved on appeal. So my information will be in the chat and in the Q&A, and I encourage any of you to reach out to me.
Yeah, thank you, Kathleen. And so, Dr. Rampal, I guess I'll move on to some questions, many of which you've received on other occasions when we've hosted these. And I know you're in the hospital today, so we're very cognizant of your time. But let's see. One of the things that you and I have spoken about before are the statistics. We have all of these people in our database, and all of whom, I think with the exception of maybe 2 or 3 that were in Vietnam, And so this question is about the statistics of the surviving Vietnam vets that have MPNs. And that, to me, that's something we can discuss further, but I do think, numbers alone kind of speak for themselves. But what would you say to, looking at some of the statistics, like what disease they have, and in my estimation, it's more PV and MF, but there are some ET patients in there. What are your thoughts about that?
Yeah, I think that might be a way to make an argument, right? So if we we have to think about how to do it, and there are various ways to do it. But if we knew that, for example, that the prevalence of MPN was higher in service members who were exposed versus what we know to be the case in the general public, that would be, I think, a reasonably strong argument, right? Because again, we're dealing with a disease in general that is not common. In 1 in 100,000, and so any small increase in numbers and in a population like veterans who were exposed probably would be enough of a signal, right? And, thinking about the what we were talking about with the MGUS, right? It was a 2.4-fold difference, not a huge difference, but a difference, and I think that's sort of what we're looking for.
Mm-hmm. Mm-hmm. Okay, so we're going to go all over the board here. Do you know of any long-term effects of hydroxyurea therapy?
An interesting question, and there's a lot of opinions about this, right? I mean, hydroxyurea can have a lot of different effects, and that can include skin cancers, oral ulcers, skin ulcers, hair thinning. Those are some of the more common, not frequent, but common side effects. Now, the question that always gets raised is, does hydroxyurea cause leukemia? And there are definitely proponents of that idea in the MPN community. I think all we can really say is that there have been studies that have been done where that has not been established. When we've seen long-term exposure to hydroxyurea, does it remain a concern and a question? Yes. But I think what we're lacking is any definitive data that it does. But skin toxicity is a real thing with hydroxyurea, and every patient that we have here on hydroxyurea, we try to, at some point, have a conversation about having them see a dermatologist once a year.
And so when our patients that are with us today that are veterans that were exposed to Agent Orange or dioxin, is there anything special or anything in particular that they should be discussing with their oncologist or hematologist because of that? So they already have the MPN, let's say they have PV, and quite possibly they never really discussed the subject of exposure, unless that came up somehow. So is there anything in particular that you would say, you should probably mention this, or I would say yes, but any other things that you can, any other?
Yeah, I think that, this may not be something that everyone is all physicians are well aware of, but because there's a known association with other cancers, I think the thing that, if I see that in history, we have to be careful that that patient has all of their normal regular cancer screenings, with particular attention to some of the diseases that we know have been linked to Agent Orange. But I think either way, if we see that in somebody's history, it's really important that they have all of their cancer screenings, because there may be some increased risk.
Yeah. One of the other questions, which I believe you and I have talked about, are there any spouses or children who lived on bases during the member's activity, or duties of their service, who were impacted with an MPN? Now, I read 3 papers years ago when we first started this, that talked about second and third generation of individuals, in families, the offspring of patients that had an MPN. And I'm guessing that if they had some exposure, if they were living on base where Agent Orange was stored, and this could happen in the US. We have some vets that I believe were at Fort Bragg or some of these other places that were storing Agent Orange and loading them onto planes and so on. So your thoughts about that?
It's an interesting question. I have personally not come across that. Like in a patient who's diagnosed, I've not found anybody who's had a history of living on a base, not as a service member, but as a family member. So I don't know the answer to that question. Is it conceivable? Absolutely, I think it is. I think more so from having had exposure than any sort of transmissible, genetic event. But it is plausible.
Yeah, I agree wholeheartedly. So you mentioned the Superfund sites in Pennsylvania. I was very active in that, I'm proud to say. And in fact, flew there a couple of times and met with patients. And Dr. Hoffman and I went to a couple town hall meetings there. We actually got the CDC involved and some other folks, Senator Specter, who is no longer with us. But when he crossed the aisle to the Dems, when Obama was elected, Obama allocated $10 million to the study in those 3 counties. And, it was pretty evident, Superfund sites, if you don't know, that's where a lot of toxins are buried. Sometimes they're not buried so well, but and they're dangerous and can be very, very disastrous to a person's health. And there were parts of those counties where the grass was actually spongy. from, near those places. But in a 3-mile radius, there were hundreds of people with PV, with polycythemia vera. So, and other diseases, it was like, what was the other area? Love Canal, it was really similar to that. Poor people living in this area, trying to survive. And interestingly, and I think the story, Raajit, but a hematologist who grew up in that area left and came back, and he started seeing all these patients and started discovering that they had PV, mostly PV. But so, I know that there is a way to do this. We just have to figure this out, a little longer. And unfortunately, the pandemic kind of stalled things for all of us. But I also want to let you people know, whoever's listening, that when new administrations come in, new stuff happens. And so, and one of the things that can happen is you get new leadership at the Veterans Administration, and they might not be as amenable to what you're bringing to them, and what information you have. And so lots of political things can change things as well. Let me see some other questions here for you. Stay with me here. Raajit, what about arsenic? I mean, have there been, I know there have been studies with benzene, which is pretty pervasive, but what about arsenic?
There is some known association with arsenic with a variety of different malignancies. With MPN, I'm not exactly sure about that. Although I will say the one strange and curious thing is there is data coming out about arsenic potentially being a treatment for MPN from Jean-Jacques Kalajian in France. But yeah, I'm not aware of a direct link with the disease itself.
Okay. So just talking about the MPNs in general, so let's talk about PV and MF. And how about a little bit of what's going on in clinical trials right now? We talk about this a lot over the last few months because the ASH conference is coming up in December. That's the American Society of Hematology. And that is a very important meeting because so much happens there, and you'll get some updates from some of our industry partners when we come to a close here. But what is coming down the pike? I mean, what do you see as some hopeful possibilities for our patients?
Oh, this is just such a tremendously exciting time. There are so many new things on the horizon. It is unbelievable. I think after ASH, there's going to be a lot of updates. There's a lot of abstracts that are being presented. But, for PV, which has been neglected, maybe that's too strong of a term, but maybe not. For many years, right, we've been talking about hydrea and interferon probably for decades now. And now things are changing. Things are evolving rapidly there. There's a new form of interferon that's approved in Europe called ROPEG interferon that looks really good. It worked better than hydrea in terms of controlling counts, and that's what got it approved in the EU. We're hopeful we'll get it here in the United States, and if we do, that will change things. I think that may become the preferred treatment, and there's data, of course, to support that. Along the same lines, one of the really interesting things that has developed in the last 2 years is that the Italians actually did a study. What we've been doing for years in PV is saying, well, there's low risk people who are young, and we phlebotomize them, and there's high risk people, and we give them interferon or hydrea. But they asked the question, well, should we treat PV people earlier? What happens if we give the younger people the interferon? And, looked at how they did versus patients who just got the phlebotomy. And as it turns out, that looked like there was actually less progression of PV in people who were treated early on. And that was one of the major topics and questions we have to think about in the MPN field is, are we waiting too late to treat people? Should we be treating people earlier than we are? That's what this study has raised. And I think there's more to be done there and more to learn. So that I think is exciting. There's a new drug that interferes with iron metabolism that looks like it may be able to control blood counts. I think that's an exciting new development. So there may be a lot of, number one, new drugs in PV. Number two, new ways of thinking about how we treat PV, and maybe not letting people get sick. MF is really exploding with new things, and there's a variety of new drugs. Many of which are actually in late stages of development, meaning that they're in the confirmatory trials. If the trials are positive, there's a high likelihood those drugs will get FDA approved. And there's too many to kind of go through individually, but there's 3 big phase 3 trials going on for drug approvals right now. And then there's a number of other agents that are being studied in earlier trials. So my prediction is that in the next 3 to 5 years, how we treat these diseases will be very different than how we treat them today.
So someone just asked, did he understand correctly that hydroxyurea can cause skin cancer?
Yes, there is a known association with hydroxyurea and something called squamous cell cancer. So I think it's really important that if you're on hydroxyurea, you should see a dermatologist once a year just for a general skin checkup.
And many people take it for years and don't have a problem. So, it just depends on who's doing what. We've had some Jakafi patients get squamous cell cancer as well. And so, it just depends. And so one of the other questions was, a person with comorbidities. So this gentleman has prostate cancer and heart disease, which I hear all the time from Vietnam vets. It's very sad. And that heart disease seems to be a part of their medical history now. And so would you say, this question I think both of us could answer, and that is, do you think their claim would be, better accepted because they also have those 2 diseases, which are on the presumptive list? And I would say probably they probably might say to you, yes, this is for prostate cancer and for heart disease, but it's not for the MPN, so, or something like that. But
yeah, I agree 100%. I agree with you.
Yeah. And Raajit, one of the other questions, which this is such a curious thing, we've talked for years about this, and that is, do you see any difference in the blood, any activity, any, the way your patients respond to things, or the symptom, the symptom burden with your VA, your veterans? Do you see any difference?
I haven't. I've had a few who are more symptomatic with their PV, but it's actually no. Several who are more symptomatic. Is it really different than the other patients we take care of? I don't know. It's hard to say that, but so I can't say for sure.
All right, and this is definitely an issue. Many of our veterans say that their physicians are unwilling to write a letter. And even if we gave them that language, they might be hesitant. Is there anything you can tell us from the physician's point of view of how you might overcome their, desire to not get too involved or not say too much?
Yeah, it's a tough thing, but I think here, what the letter says fundamentally, right, is that we're never stating in the letter that that exposure caused the disease, because that is not a statement that I can back up with any evidence at this moment. But what one can say is that if you look at somebody's history, right, and somebody has had an exposure, but otherwise nothing else has really happened in their life, you reasonably say it is likely, or it is more likely than not, that this exposure played a role. That's a legitimate argument, right? You can definitely say that. It's harder in somebody who may have, let's say, had an exposure, but then worked on an oil refinery for the rest of their life, or they worked in the oil or gasoline business where they had exposure. That's a harder thing to make an argument, because you could reasonably say it was the other thing that caused it. But in somebody without any other thing in their medical history or their family history that would predispose them to an MPN, it is a reasonable thing, I think, to make an argument that this factor is more likely than not to have contributed. So I think where some of the hesitancy comes in for physicians, they don't want to be in a position where they are writing down this caused it, this definitely played a role, because nobody can say that. That's not a factual statement, but you can make a probabilistic argument. I think that if introducing it that way is a more reasonable thing, and even showing them the letter as we've written it may help sway their opinion.
All right, so this person says, I did write that and he still would not sign it. Can I have the VA doctor do a letter? And I would say, yeah.
Yeah, if
I
they're
mean, you
willing.
might as well, if the veteran, if your person at the VA, local VA will look at that and say, and again, just to back up with what Dr. Rampal is saying is, he was very careful in his language in that letter, as he needed to be, to say it's probable. He cannot say it's actual and this is why, so it's important to use that kind of language, because you'd never be able to back it up or substantiate it if you said it's, this is what it is. We hope that in the next year we have better news and better hard evidence. It's going to take time, and money and energy, and we're on board. We always have been on board. But I just want to reiterate that we are going to go talk to some folks at the VA about this disparity and why it exists and what we can do to change it. The other thing I wanted to mention before I forget, and that is some women, female spouses, have been able to get benefits retroactive after their husbands have passed. And so if you are in that position, if you're with us today and your spouse passed away from an MPN, you may be able to get benefits, retroactive benefits. And I think we have information on that as well on our website. And I apologize for the light changing in here, but we have thunderstorms going on. So it's getting dark and then bright and dark and bright. All right, so moving right along. So Dr. Rampal, have you had any patient come to you that has had, for example, we know somebody that worked for the auto industry, and her, in this case, a female, her job was to wash the parts in this tub of benzene. Okay. She had to wear gloves up to here, up to her elbows, and submerge this stuff in benzene and bring it back up. And she said many times the benzene would get under her skin, under the gloves and so on. So we know that there are papers written about benzene and the link between benzene and blood cancers. So what are your thoughts about, have you seen or worked with patients that have that exposure, that you think this is another avenue we can take with our Vietnam vets?
Yeah, no, that link is really, that has been well established. Benzene is a toxin, and it absolutely is associated with blood cancer, which has been known for decades, right?
Yeah.
One of the things we always do when we meet a new patient is we ask about their work history, right? Were they exposed? Does it make sense? I've seen this many times where somebody develops it and then we go through their history and it turns out, yeah, that's exactly the same story, right? That they worked with machine parts or machine solvents, those types of things. To me, that's absolutely a risk factor. But those are important questions that doctors have to ask when they're meeting a patient.
So what are some things that the people on this call today, just in terms of taking care of their health and with an MPN, and what they should be doing to improve symptoms and those types of things?
Yeah, I think there's a couple of things that are important. I always tell patients that when they have one of these diseases, it's sort of like having diabetes. Like when somebody has diabetes, what we tell them is, their risk of heart attack and stroke and becoming disabled and having kidney failure all go up, right? If their disease is not well controlled. And to me, we've got to think about MPN the same way, that when people have this diagnosis, it's important that all the other parts of their health are really adequately managed, right? So, one of the common ways people come to us is that, and this is typically men who come to us this way, they haven't seen a doctor in 10 years, somebody makes them go get a blood test, or they need surgery and they get a blood test, and lo and behold, it's abnormal, and they get diagnosed with an MPN. This is a pretty common story. What the implication to me there is that the other aspects of that person's health have not necessarily been well assessed, right? Is their cholesterol good? Do they not have diabetes? Are they, not at risk of heart disease? Those are important things for everybody. But when you have an MPN, which we know increases the risk of clotting, of heart attacks, strokes, all of these things, those other parts of your health are essential, right? And how do you manage those things? Well, those things are managed partially by medications, but more ideally by being active, eating the right things, all of those things, all of the things that our mothers told us are actually true, right? Those are the basic things that have to be done. And they actually get more important, in my opinion, as we age. So those are things that are fundamental. And I know, and you always talk about this at the beginning of a lot of our meetings about wellness, right? Well, we have to think about health and wellness together. Wellness is a proactive thing. That wellness is something you do to maintain your health, not to heal something necessarily, right? And things like staying active, being active, those are huge, absolutely important parts of how you have to take care of yourself in general, but particularly when you have a disease that is not a short-term disease, but a long-term disease.
Yeah, it's a chronic disease. So, and we know that fatigue is the number one issue that our patients suffer from. So, I sometimes get embarrassed when I start talking about, just get up and walk down the street or do this or do that. And the reality is some days you're just not going to feel like it. And that's okay. But if you're not smoking cigarettes or, putting other substances in your lungs, if you're not putting things in your body that are potentially dangerous to you and to your health, and we do have control over what we eat, and we do have control over what we drink, and if we smoke or don't smoke. Those are things that don't necessarily force you to get up and walk 2 miles, but I do think, we've all discussed this, all of us over the years, and that is blood flow. And if you're sitting in one position all day or, for days on end, that's probably not so good for you. If you really can't get up, then you can't get up. But if you're drinking enough water and staying hydrated and eating properly, those are simple things that you do have control of and can do. There was a question that came, let me double check here. Oh, what can you tell us about Inrebic or fedratinib? A physician, an oncologist has recommended this for a patient who says he's heard things about mental health effects of the drug.
Yeah, I think probably what he's referring to is when the trials were being done with this drug, there was a really rare neurologic phenomenon called Wernicke's encephalopathy, which causes a lot of neurological alterations. And that led to the FDA actually holding the trial from going forward. When it was reevaluated, it didn't look like there was a clear association. I think there was only a handful of cases ever found. So that is something that is in the label of the drug as a caution because it was seen in a really, really small number of patients. It's really not clear that it's related to the drug. It is something that we have to discuss because it was seen during trials of the drug. That phenomena is usually called by a deficiency in thiamine. It happens in alcoholics, for example, who don't eat. And so they get deficient in things like thiamine. So one of the precautions we take are that we check people's thiamine levels and we give them thiamine if they're going to go on fedratinib.
Okay. And so I haven't heard anything, since that case, I haven't heard anything else about that. So I think we're okay. And the FDA surely would not approve well, it's happened, but they would not approve a drug knowingly, if it were dangerous to us. And so, and we do know people that are taking the treatment without any problems. So.
Absolutely.
So in your closing, and then we're going to go to our industry partners. And today we have our partner from the LLS with us because, as I mentioned earlier, we can provide a lot of things and mostly direction, comfort, information, education, and so on to our patients. But the Leukemia and Lymphoma Society can offer things that we can't. And so you will be hearing from Amy Lane from LLS. But in closing, Raajit, I know you have to get back to your patients. What else can you share with us that, for the future in MPNs and the future of our work?
Yeah, sure. I think that, those are important points, right? As I said, MPN in general, I think this is exciting times, so many developments going on. And, not only with just medications, but how we think about the disease. And, we're beginning to hopefully some of the things we've been doing with the MPN Foundation is trying to move the discussion into how do you prevent it from getting bad, right? Why are we focused only on treating the disease when it's really bad? Why are we not focused on preventing it from getting bad? And that is a huge shift in how we're thinking. So that's something I want people to be aware of. And that is something we hope to be writing about soon that will be, hopefully available to the patient community so they can be aware that we're beginning to think differently about how we approach the disease. There's a lot to be optimistic about. There's a lot of challenges too. And it varies by where we are. I think that, I just gave a lecture in another country, virtually, of course, this morning. And they were talking about the fact that they can't have Jakafi or JAK inhibitors. It's just not available to their population. What do they do? So there are significant challenges for us here, but across the board in these diseases. But I think there's a lot of things that are going to make a difference soon. With regard to, everything we're talking about today, I think that maybe, as I said in the beginning, I think this is an important thing. And as I said, if you forget everything else, this is a morally important thing to look into. And we're doing it. And, I don't want to, I certainly can't promise we're going to have an answer because there are a lot of challenges here without a doubt, but we're working on it. Right. And we've started to engage with people who we think can help us with this. And there is precedent here, as I've shown you with this, study that we talked about. I think there are ways forward to address this question, and hopefully we can resolve this.
Yeah, I agree. And I, before we say goodbye to Raajit, I just want to say, and I'll say it again, thank you to all the veterans that are here today and for those families that were here. And my dad was a World War II veteran. I know that he had some chronic illnesses based on the work that he did in that war. And, it's my brother was in the Vietnam War, but he was not in Vietnam. He was not exposed like most of you have been. But thank you so much. And I agree wholeheartedly with Dr. Rampal about the moral issue here. You were promised a lot when you were either drafted or enlisted on your own. And some of those promises fell short when you came back. And, I'm sorry for that as a US citizen. But we're doing the best we can. We have worked many hours on this. I'm so sorry when I have to say there isn't much new at this point, but we're getting there, and we're going to take a different approach and hopefully make some inroads. And Dr. Rampal and I will be in touch, and we'll be working in ways that we hope will get to the place where MPNs are on the presumptive list. And sometimes it just takes a village, as they say, but it's a good point because, you know, the more people are involved, the better. And the more we hear from you, the better, because we can put your stories together and keep your names and know that you are out there and do the best we can to help you. So thank you. You're welcome to stay on with us while we introduce our partners. But I know you probably have to get back to your patients. I really appreciate you being here today, Raajit. It means a lot to me.
My pleasure.
Okay.
And it means a lot to be here. Thank you so much.
We'll talk soon.
Bye.
Bye. So now I would like to introduce, you know, we have industry partners, and they are the people that help the machine to keep rolling here. And we really like to have our patients that join us stay with us during this time for their updates, because these are people that are working tirelessly as well in clinical trials, bringing new drugs to the forefront. And so it's important to hear from them. They get 3 minutes to give their brief updates of these programs. But I first want to introduce one of our organizational partners. We have many. The MPN Research Foundation is one, and LLS is another. And again, as I mentioned, they do things and can offer resources that we cannot. So we typically will direct people that way to them. But I'd like you to meet Amy Lane, who's an information specialist at LLS. Hi, Amy.
Hi, Anne. First, I'd just like to say thank you, Anne, and thank you, Dr. Rampal. It's no longer on, but just for your important work. Thank you very much. And thank you for inviting me today to speak. First, I just want to say that it's an honor to be here with the veterans, especially on Veterans Day. So as Anne mentioned, I'm Amy Lane. I'm an information specialist. I'm just going to share my screen. Okay. Okay. Are you able to see?
Yes.
Just the slide, the plain slide? Okay. Yes. All right. So my name is Amy Lane, and I'm an information specialist with the Leukemia and Lymphoma Society. And I work one-on-one with patients, with caregivers, with healthcare professionals, and we provide guidance and resources to help patients and families, kind of navigate the process. So I know we do have a full agenda, so I'm just going to get right to it, who we are and what we offer. So our mission is to cure all blood cancers and improve the lives of patients and their families. We have a research arm where we've invested over $1.3 billion since our founding more than 70 years ago. And we've contributed to many of the approvals of blood cancer drugs. We also have an advocacy arm, so we have a presence in Washington with that goal to improve patients' access to care. And we also offer direct support to our patients and families, which I'll focus on just for the last piece of my presentation. So just in a nutshell, this is basically kind of a listing of what we offer, and we offer quite a bit, both financial, educational, and support. And I encourage you to give us a call. We'd love to meet you. Encourage you to, we're here from 9 to 9 Eastern Time. And our number is at the bottom there, the 800-955-4572. But just to give you kind of an overview of what we offer, first and foremost is financial resources. We have several funds available, from time to time, and it depends on eligibility as well. And that includes travel funds, and that includes for gas and tolls and parking, lodging. We have a patient aid grant, which helps with any type of expense. We have an urgent need fund to help with non-medical expenses, and also copay and insurance premium assistance for some blood cancers. We were thrilled because not too long ago we received approval to start an MPN copay fund. So we're currently working to get some funding, and so that we can open that up to folks. But in the meantime, we do keep a list of organizations that do provide funding to help with MPN medications. So we can help guide you on that as well. And then we've also built a comprehensive list of organizations that have that provide a variety of resources by need. As far as education, we have webcasts and podcasts, education booklets, just to keep you up to date on the latest treatments and what's in the pipeline. We have blood cancer conferences and up-to-date information on COVID-19. And then last, we have a lot of support resources besides our information specialists. And what we do, we help you find MPN specialists, help you find specific resources. If you just need a sounding board, we're there for you just to listen and help you find and stay on a healthy path. We have nurses also who perform clinical trial searches if that's of interest. We have also a registered dietitian that gives free phone consultations if you have side effects or just want some basic nutritional guidance. She's wonderful, been in the field for over 10 years. And her work extends not only to the blood cancers, but other cancers too. We also have special resources for caregivers as well. We have a wonderful caregiver package, which is a binder with all kinds of guidance, calendars, pill box, and the kitchen sink to kind of help guide you. So I hope you'll give us a call. We'd love to meet you, help you in any way that we can. And I'll conclude there. So thanks again for this wonderful opportunity and to be a part of the event today. Thanks, Ann.
Thank you so much, Amy. And, we have a lot of crossover, but it's okay because we don't offer the copay, and the financial resources. I was so glad to hear you say that. And there are several things that we can't do that you do. And I'm glad you listed those because that's very important that our patients know about that. Thank you so much for joining us, and we'll move right along because we don't have much more time. But I'll be in touch, Amy, and thank you so much.
You're welcome.
And so we will move on now to Insight Corporation and Kristen Murray, who is an oncology nurse educator, and hear from her. And just to let you know, Insight has been supporting us for years and has made many of the programs that we host possible. Thank you.
Thank you, Ann. And happy Veterans Day to all our veterans out there. I'm very pleased to be here today to represent Insight, and I would like to thank Ann and team at MPN Advocacy Education International for giving me a few moments to speak about our company and its commitment to patients. I am grateful to have the opportunity to participate in today's meeting and meet so many people who are impacted by the diseases that our company is focused on. We work and study these diseases on a daily basis, but value these moments I get to hear your voices and questions what is important to you and how we as a company can help to be part of a community of support. So Insight Corporation is a Wilmington, Delaware-based biopharmaceutical company committed to making a difference in the lives of patients through scientific discovery. So rigorous science is at the core of everything we do to discover, develop, and deliver novel medicines that will meet the serious medical needs in oncology and other diseases. One of our most important commitments is to help ensure that appropriate patients may have access to the medicines they need. For this reason, we developed a patient support program called Insight Cares to help appropriate patients and healthcare providers access their prescribed medication. So information for patient access can be found at www.insightcares.com. We are currently enrolling eligible patients in clinical trials for MPNs. If you're interested, please contact your healthcare provider. Detailed information about Insight's clinical trials can be found at www.insightclinicaltrials.com. We strive to enhance support in the patient community and to integrate the authentic patient voice throughout our initiatives. Partnerships like the one we have with MPN Advocacy and Education International have been key in helping our understanding of the unmet patient and caregiver needs, including raising disease awareness and providing educational information to the community. We host a website called Voices of MPN, voicesofmpn.com, where we provide access to MPN information, patient stories, access and information for MPN community events, patient meetings, podcasts, and symptom tracker tools. We created a program called MPN Heroes to publicly recognize individuals who have excelled in caring for a patient or patients with an MPN or have advanced the science in MPNs to increase awareness and support the MPN community. So MPN Heroes will take place virtually this year on Wednesday, December 8th at 6 p.m. Eastern Time. And our keynote this year will be LeVar Burton. Cure is hosting this event. At Insight, we believe that industry and patient groups can find common ground to develop collaborative partnerships resulting in meaningful activities. Programs like this allow Insight to use our resources to help improve the lives of individuals most impacted by the diseases in which we work. And with that, I will conclude, Anne, and I thank you so much for the opportunity to be here.
Oh, thank you so much. I really appreciate it always. We have to move along, and with Geron Corporation and Denise Meyer, who is the VP of Medical Affairs. Are you there, Denise? Okay.
Hi, Anne. This is
There you
Tamara.
are. You're Denise Meyer, sorry.
Oh, yes, I'm sorry. Thank you so much for the opportunity to speak today, Anne, and for the MPN Advocacy for holding this important conference today. I just wanted to thank all of the veterans on the line for their service. We really appreciate everything that you've done for this country. As Anne mentioned, my name is Tamara Berry, and I'm an executive director in clinical development at Geron. So Geron is a late-stage biopharmaceutical company, and we are developing imetelstat, which is an inhibitor of telomerase, and this is targeted for treatment of hematological malignancies. We completed a phase 2 study of imetelstat in intermediate 2 and high-risk myelofibrosis patients who were relapsed or refractory to JAK inhibitor treatment. This study was known as MYF 2001 or EMBARK, and it showed a potential for survival benefit as well as encouraging symptom responses in this patient population. So subsequently, we have recently opened a phase 3 study in intermediate 2 and high-risk myelofibrosis patients who are refractory to JAK inhibitor treatment. This study is known as MYF 3001 or IMPACT MF. So IMPACT MF is an open label randomized controlled trial comparing imetelstat to best available therapy. The primary endpoint for this trial is overall survival, and symptom response rate is a key secondary endpoint. We plan to have over 100 sites globally to enroll in this study. And you can find more information about our study on the Geron website, geron.com, and also on clinicaltrials.gov. So with that, again, I would just thank you, Anne, for the time today. And thank you for this important meeting, and thank you to all the veterans. Happy Veterans Day.
And thank you, Tamara. I'm sorry that I had the names confused because Denise was with us. And so I apologize very much for that, but thank you. We appreciate it. And we appreciate the support we've gotten from Geron as well. And next we will hear from AbbVie and Brian Murray, who's the Medical Affairs Director. Hi, Brian, how are you?
Hi, Anne. Good to see you again.
Good to see you too.
Thanks for having me here, and thanks to all our veterans for joining us here on Veterans Day. I know we are very short for time, so I'll try to keep this as brief as possible. As Anne mentioned, I'm with AbbVie, and AbbVie is currently developing a new drug for myelofibrosis called navitoclax. Navitoclax is not FDA approved. It's currently in clinical trials, and I'll talk about some of those trials that are ongoing and looking for patients. Navitoclax works by affecting a pathway that normally cancer cells would use to keep themselves alive, and it stops the cancer cells from doing that, including cells in myelofibrosis. That's just a very kind of general overview of what the drug does. And we're currently investigating Navitoclax in 2 phase 3 studies that are actively seeking myelofibrosis patients. These are called our Transform studies. So Transform 1, which is our phase 3 study, where we evaluate combining Navitoclax with ruxolitinib compared to ruxolitinib and placebo. And that's for patients who have primary or secondary myelofibrosis, who have not received a JAK inhibitor. So if you haven't yet been treated with ruxolitinib and you were recently diagnosed and you speak with your physician and determines that he or she determines you need treatment, this is a potential, this trial is a potential option. Our second study is called Transform 2, and that's for patients who have myelofibrosis who have progressed on ruxolitinib, and that will study Navitoclax combined with ruxolitinib compared to best available therapy, which is your treating physician's choice of therapy. So we are actively seeking patients for these studies. We're enrolling across 30 plus sites across the United States. For more information on these studies, because I just gave you a very brief overview, please check out myelofibrosisresearch.com. That's myelofibrosis research, all one word, and you'll get a lot more information on the eligibility criteria. I just covered it, I just covered 1 or 2 very briefly to see if you may be eligible for the study if you're interested. There's a questionnaire to determine your eligibility, as well as current study locations and frequently asked questions. But of course, you'll want to speak first with your treating hematologist to see if a trial is something that you want to consider. So again, myelofibrosisresearch.com. And with that, I'll pass things off to the next presenter. Thanks again, Anne, everyone, for having me here. Appreciate your time.
Thanks, Brian. I'll see you at ASH. Okay, thank you so much. And now Pharmacentia, who is also one of our partners, and Denise McNeil, who's the medical science liaison. Hi, Denise.
Hey, Anne, how are you today?
I'm good, thank you. It's good to see you.
It's good to see you again. Thank you again, Anne, for having me today. And thank you for all the work that you do with your group. It's an amazing amount of work, and I'm very honored to be a part of it today. I also want to echo the thank you. There can never be enough thank yous, in my opinion, to the veterans. Thank you again to all the brave men and women that serve our country. There are no words to describe how much it's appreciated. So thank you again. I have a quick slide to share just to help. It'll be brief. Let me make sure I share my screen real quick. Okay, can y'all see that?
Yeah.
Perfect.
Yeah.
So again, on behalf of Pharmacentia, I'm very happy to be here to give a little high level, super brief overview of the work and the research that our company does with regards to patients with MPN. Specifically, I do want to highlight the work that we've been doing with essential thrombocythemia, and it's the SURPASS-ET study. And the goal of this study is to evaluate the efficacy, safety, and tolerability of ropeg interferon. And here we're looking at its second-line therapy for patients with ET who are either resistant or intolerant to hydroxyurea. You can see the format of a phase 3 study. The duration will be about 14 months, pretty standard. And also, oops, I think I went 2 down. I wanted to mention that enrollment is ongoing and started. That's something I wanted to make sure to mention when we talk about the SURPASS-ET study. It's a global study, and we have about 50 sites worldwide, several sites in the US, Canada, and then also in Japan, Taiwan, China, South Korea, as well as Hong Kong. So here's a couple of sites to go to for some information. Please go to clinicaltrials.gov and type in some information there. You'll find a lot of information there. And also on our microsite, surpasset.com, you'll also see a lot of information there. And our hope here is that this information can be shared with family and friends and loved ones, so then they can go and have that conversation with their physician, so they can decide together if this is a good option for them to enroll in.
Thank you so much, Denise. We really appreciate that. And we're really looking forward to post ASH and ASH, as you've got exciting news going on there. So
We are very excited to, very excited.
we're
And
pretty happy. And so thank you so much. And we will move on now to CTI Biopharma and Raajit Rampal. And he's the Pharm Medical Medical Science Liaison. It's
Hi,
the
Ann.
new term this year, MSL or MSL. I hear that all the time now.
Hey, Ann, yeah, I'm also going to share my screen.
Okay,
All right, let me know when you could see that.
I see it.
All right, thanks, Ann, and the whole MPN Advocacy and Education team for today's session, and a thank you to all past and present servicemen and women on this Veterans Day. My name is Raajit Rampal, and I'm a medical science liaison with CTI Biopharma. We are developing pacritinib, a JAK2 IRAK1 inhibitor for patients living with myelofibrosis and experiencing low blood counts. The FDA accepted our new drug application under accelerated approval for pacritinib in patients with myelofibrosis, including patients with severe thrombocytopenia or platelets less than 50,000, which underscores the unmet medical need in this area. The target action date from the FDA is November 30th, so we're hoping to have some good news here before the holidays. Pacritinib has been studied in over 1,200 patients, including the completed phase 3 PERSIST clinical trial program in patients with myelofibrosis. And we are currently enrolling in our pivotal phase 3 Pacifica study of pacritinib versus physician's choice therapy. Pacifica enrolls patients with myelofibrosis and platelet counts less than 50,000. This study is open to patients who either have had no prior exposure to JAK inhibitors or who have had a limited prior exposure. The study enrolls patients who have splenomegaly and symptoms related to myelofibrosis. Patients are randomized 2-to-1 to pacritinib or physician's choice therapy, which includes low-dose ruxolitinib, danazol, hydroxyurea, and corticosteroids. Enrollment is now underway both in the United States and worldwide, and you can find out more about this trial on clinicaltrials.gov. I also wanted to share with you the launch of Inside MF. This valuable resource features insights from top myelofibrosis experts on managing patients with myelofibrosis, and more importantly, it brings to light the impact that cytopenic myelofibrosis has on patients living with it. The resource aims to bring together patients, caregivers, and hematologist oncologists to better understand myelofibrosis and find new paths forward in managing this disease. And again, that website is insidemf.com.
Yes.
Our team at CTI, Ann, apologize, I just wanted to say thank you, and that we remain excited by our partnership with the MPN Advocacy and Education International.
Yes,
Thanks
we've
for the
been
time.
partners a long time, and I've watched this drug go in many different directions, but it's going in the right direction always, and it's another one that we're paying close attention to at ASH and for the future of our patients. Thank you so much.
Thank you.
And moving along, we'll go to Cartos, and Andrea Blank is the Vice President of Medical Affairs. Hello, Andrea.
Hi, Anne. Thanks so much again for having us
Welcome.
today. I'm also going to just share my screen, and if you can just let me know you all can see it. So one sec.
I see it.
Great. Wonderful. Well, it sounds like you all are getting a lot of great information today about a variety of companies. To also speak with you today, my name is Andrea. I'm a nurse practitioner by training and now work at Cartos. We have a drug in development called navtemadlin in a variety of trials in myelofibrosis and other MPNs. This is just a highlight of a few clinical trials that we have open. But what I would love to draw your attention to is a trial that's specifically called Boreas. It's a phase 3 trial with what's called KRT-232 or navtemadlin. That's an MDM2 inhibitor, which reactivates P53 in myelofibrosis and other MPNs. And like I said, this is a phase 3 trial that's ongoing. This is the website that has more information, boreas-trial.com. For those that would like to go and learn more about this clinical trial in the phase 3 setting. And additionally, we also have our website at the bottom of this screen so that you all can visit that to see the other trials in MPNs. As I said, it is a MDM2 inhibitor, Certainly you've heard about some very other exciting therapies today. So I just wanted to say thank you guys for joining us today, and thank you to you and your team for hosting. And then of course to our veterans and the family and friends that support them. And just a lot of gratitude on today and for everything you both have done and continue to do for us. So thank you very much, Anne.
Yes, and thank you very much as well. And again, you know, if you're a patient or a family member of a patient watching this today, there is so much hope and so many things happening and for the future and for the betterment of the MPN community. So now we'll hear from protagonists and Paula O'Connor, who's the Senior Vice President of Clinical Development. Hi, Paula.
Hey, how are you? So first and foremost, I want to echo the thanks that has been given by everyone on this call, not only to you, Anne, and your team at the MPN Advocacy and Educational Foundation, but also, and most importantly, if you will, to the veterans and their families who are on the call today. So I appreciate all of your attention. I do want to echo one of the statements that you've made continuously and that Dr. Rampal made earlier. This is an incredibly exciting time for patients with MPNs. There are so many new agents on the horizon, many of which you've already heard about, albeit briefly today. So to the extent that, you know, it takes a village to make a difference, this village is getting bigger and broader every single day. And so for that, you, and we should all be very, very thankful. So as you've already noted, I am a physician who is working at Protagonist Therapeutics, which is a clinical stage pharmaceutical company based in the Bay Area, actually on the East Bay, Newark, California. We are working to develop a molecule called rusfertide. And as you heard from very briefly from Dr. Rampal, it is a hormone-like therapy that is designed to control iron levels in the body, and ultimately by restricting the amount of iron that's available in the bone marrow, decreases the red blood cell production or overproduction that is the signature of polycythemia vera. Since we last spoke with this group, we have restarted in treatment in our phase 2 trial, which has previously been reported at EHA, and we anticipate getting updates for at ASH this year. Long story short, our phase 2 program was designed to look at the activity and the safety of rusfertide when added to standard therapies, whether they be phlebotomy or other cytoreductive therapies such as Hydrea, interferon, or Jakafi, for patients who have continued erythrocytosis that requires multiple phlebotomies despite their pre-existing therapy. So in our ongoing phase 2 trial, we have added rusfertide to standard therapy to assess the safety and activity of the combination. We have another phase 2 that is ongoing outside of the US, and that is one where we're looking at patients who have very high hematocrits and looking at the ability of rusfertide when added to initial therapy to bring down hematocrits quickly and safely, and then to see how long those effects can be maintained. And then lastly, and perhaps most importantly, we are in the process of getting ready to institute a phase 3 trial that will begin in the first quarter of 2022, where we're looking at rusfertide once again, given in combination with other therapies, those that I've already noted, phlebotomy, Hydrea, interferon, Jakafi, in an effort to control the the hematocrit increases that occur in patients who have, if you will, uncontrolled polycythemia vera despite active therapies. So we look forward to your participation and certainly recommend that you reach out to us at either protagonist-inc.com to learn more about where the studies are being conducted in your area. Or obviously you can also go to clinicaltrials.gov, and we look forward to working with you all in the future and wish everyone a happy, healthy, and safe rest of the year.
Thank you so much, Paula. That was very nice, and thank you very much. And now we will move on to Constellation. And Shani, are you with us?
Yes, I am.
Oh, there you are. Hello.
Yeah. Hi, good to see you again, Anne.
Good to see you too.
Yeah, thank you for always providing such a wonderful platform for the exchange of updates. So this is very valuable opportunity for all of us. And thank you to all the veterans and all the patients and caregivers out there. So again, I'm Shang-Yi Liao. I'm Field Medical Director at Constellation Medical Affairs. For those of you who don't know us, we are a Massachusetts-based biotech company with over 12 years of discovery and development history, focused on the epigenetics and cancer biology. Our drug candidates were all internally discovered and are products of our expertise in gene targeting for diseases where gene regulation and control matters. As of July 15th of this year, Constellation is now a MorphoSys company, and we are committed to delivering breakthrough therapies to bring the hopes to patients. Our lead compound generated at Constellation is an investigational BET inhibitor, or BET inhibitor, called pelabresib. Also goes by the name of CPI-0610, that we are developing as a potential treatment of myelofibrosis. Pelabresib is a novel orally administered small molecule designed to selectively inhibit the function of the BET protein to decrease the expression of abnormally expressed genes in cancer. Please note that pelabresib is investigational and is not yet approved by any regulatory agency. Constellation is currently conducting a phase 2 clinical trial of pelabresib in myelofibrosis and ET, and a larger phase 3 trial called MANIFEST-2 has initiated for myelofibrosis. MANIFEST-2 is a randomized, double-blind phase 3 trial in adult patients with myelofibrosis who have not been previously treated with a JAK inhibitor. The purpose of this study is to evaluate the efficacy and safety of pelabresib plus ruxolitinib compared with ruxolitinib alone. For more information, you can find both the MANIFEST and the MANIFEST-2 study at clinicaltrial.gov or our website at constellationpharma.com. We all recognize that we need new therapies for the MF patients that address the areas of unmet need, and we are working hard to develop such a therapy. Our interest and commitment to patients and caregivers actually extends across the MPN community, as we have additional plans for pelabresib and other early stage programs that may have utility in MF and other MPNs in the future. And a final thank you again, Anne, and the MPN AEI for the great opportunity. Back to you.
Thank you so much. We really appreciate this. And again, it just floors me when I hear from so many of you and how much, the good work that's being done out there and how life is about to change for many of our patients, which is so wonderful. And so moving right along, thank you so much. We'll move on to Sierra and Lauren Musto, who's the Senior Director of Corporate Communications. Hi, Lauren.
Hi, Anne. It's lovely to see you today. Thank you.
You too.
Thank you for having us on. We really appreciate the time, and I'm super excited to share a little bit about what we're doing in the myelofibrosis space. So if we have not met before, my name is Lauren Musto, as Anne mentioned. I oversee corporate communications and patient advocacy at Sierra. And if you're not familiar with Sierra, we're actually a late-stage biopharmaceutical company, and where our mission is really to deliver targeted therapies that treat rare forms of cancer, including myelofibrosis. So our main focus right now is on the development of momelotinib, which is an investigational agent for the treatment of MF. Momelotinib is an inhibitor of 3 key signaling pathways that contribute to the major manifestations of the disease. So by inhibiting ACVR1 as well as JAK1 and JAK2, we believe that momelotinib has the potential to improve anemia of myelofibrosis while also improving constitutional symptoms and splenomegaly. We're currently awaiting our top-line results for the phase 3 momentum study, which we expect to have actually by February of next year, so less than 3 months. The momentum study enrolled 195 of a planned 180 patients who had previously received treatment with a JAK inhibitor and who were symptomatic and anemic. So the trial will assess the impact of momelotinib on symptoms, splenomegaly, anemia, and the need for blood transfusions. And then assuming the primary endpoint is met, we plan to file a new drug application with the FDA in the second quarter of next year. And then excitingly, actually, in August, we announced that we had in-licensed a novel BRD4 BET inhibitor to expand our pipeline. So SRA515, which was previously known as AZD5153, is a differentiated BET inhibitor through its high potency, selectivity, and bivalent binding, which may offer more complete target inhibition relative to other monovalent binders. And then unlike other improved JAK inhibitors, momelotinib is not myelosuppressive. So therefore, we believe the combination of momelotinib plus SRA515 may provide improved efficacy and safety over other JAK inhibitor, BET inhibitor combinations. Our plan is to initiate a phase 2 trial examining that momelotinib SRA515 combination in the first half of next year for the treatment of myelofibrosis. And we look forward to sharing more details about that as we get closer to trial initiation. So to close, Anne, I just again would like to thank you so much for inviting us here today and everything you're doing in the myelofibrosis advocacy space. And I would especially like to thank all the veterans and caregivers on the call today. Certainly we couldn't do what we do in industry without you have done for us to be able to have the freedoms that we have and do the work that we do. So thank you so much for your service and sacrifice. It is truly appreciated.
Absolutely. Absolutely. We all echo that for sure. Thank you so much. And now we will move on to Imago Biosciences and Laura Eichhorn. Are you there, Laura? Hi, Laura.
Hi, how are you, Anne?
Good. Thank you.
So wonderful to see. Thank you so much. And thank you all to everyone in the audience, Kathleen and Mallory for organizing this event and all of the other wonderful events that you guys put together. I'm going to make sure that you are seeing my screen here.
Yes, we do see.
Okay, perfect, perfect. No, you're fine.
I forgot to answer.
that is okay. So as Anne said, my name is Laura Eichhorn. I'm the Chief Financial and Operating Officer, as well as one of the founders of Imago Biosciences. As both a daughter and a spouse of a veteran, this event is very personal and important to me. And I want to take a moment to pause to recognize all of the veterans and their families, because I personally know the sacrifice that the veterans make firsthand, and the sacrifice and appreciate your contributions and your service to our country. So Imago is honored to provide its support to Anne's team over the past few years. I'm always inspired and honestly fatigued to see all of the efforts. I'm impressed by her passion and support of each and every one of you. And so whether you're a newly diagnosed patient, a family member, a support person, or a caregiver, I definitely encourage you to take advantage of everything that Anne and her team offer to this community, and all of the resources that the MPN Advocacy and Education International has to offer. A little bit about Imago Biosciences. We're a public company, most recently public back in July. We were founded in 2012, and we are also based in the Bay Area, across the bay from Paula's company in South San Francisco. We're currently focused on the treatment of MPNs, myeloproliferative neoplasms. As you know well, these diseases pose a great challenge to the physicians as well as the patients and their families. The approach of our drug, bomedemstat, is to target genes that regulate blood formation, specifically those that are regulated by epigenetic enzymes such as LSD1, an enzyme that regulates the maturation of blood cells in bone marrow. Our drug bomedemstat, or IMG 7289, was discovered by Imago in 2015 and is an LSD1 inhibitor. It's an oral medication in a capsule form taken once daily. In 2016, we first studied patients with acute myeloid leukemia. A year later, we transitioned to treating patients with myelofibrosis. We just recently wrapped enrollment and enrolled the final patient in our phase 2 myelofibrosis study. The goal of the treatment of the myelofibrosis study is to improve both the symptoms as well as reduce the spleen size and reduce the number of malignant cells with the hope of changing the outcome for the patients. Bomedemstat is also being studied for the treatment of essential thrombocythemia with the goal of reducing the platelet count to a normal level. I want to emphasize that we're still in the clinical research phase in all of these indications, and this drug is not yet approved by the FDA. However, the FDA has granted bomedemstat fast track status for both the treatment of myelofibrosis and essential thrombocythemia, and bomedemstat was also granted PRIME status in the EU, a status that's given to drugs that hold promise for new clinical benefit and for patients. So the myelofibrosis study, as I said, was fully enrolled back in the spring. We present quite frequently at the hematologic meetings, given that our drug is an open label study. Most patients have experienced improvement in their symptoms and shrinkage in their spleens in the MF study. And we have most recently been able to show a reduction in the number of malignant cells, which is a very exciting result in this study. This was anticipated, however, because we did see this observation in our preclinical research. We will be presenting 2 oral presentations at the upcoming American Society of Hematology meeting in Atlanta next month. A little bit more about our ET study. As I said, we have a phase 2 ET study, which is currently enrolling patients for ET, and data for this study was presented earlier this year at the European Hematology Association meeting. For more information on these studies, please visit the websites that you can see on your screen here. Here's just a little bit of an idea of where we are with these studies. As I said, we have completed enrollment in the myelofibrosis study and still openly enrolling in our essential thrombocythemia study with many clinical sites both in the US as well as globally. Lastly, we are also studying bomedemstat in polycythemia vera with a single site investigator-initiated trial at the University of Miami. And in the coming months, we will be beginning a study, a combination study of bomedemstat and with the addition of ruxolitinib for the treatment of myelofibrosis. So to learn more about any of our clinical research, please either visit our website, imagobio.com, or the 2 clinical study sites that you see on your screen here, or visit clinicaltrials.gov for the latest and greatest clinical information. And everyone, thank you so much, and thank you all to the veterans.
Thank you very much. And we are going to leave you now, and many of you know how to reach us, obviously, and a recording of this will be available next week, probably on Monday or Tuesday. And if you have MF, join us on Tuesday. Doctors Brady Stein and Linda Rizar will be joining us, and it'll be a conversation with the specialists. So send your questions. We do have questions from previous events about MF, but if you have others, please send those and join us on Tuesday. Thank you we can't thank you enough, all of our veterans and the families of veterans, and try to find some peace today. Thank you so much. Bye.